Great. Well, today we're going to talk about addressing ageism in medical education. I'm Elizabeth. I am the current MedEd Fellow at Emory.
My name's Nikaylee. I was a former MedEd fellow, and I'm faculty at Emory now.
Hello, everybody. I'm Marta Rowe. I'm also faculty at Emory and the Med Ed Assistant Director.
And we will be doing a little bit of microphone popcorn today. I should probably use this too. So our objectives today, we are going to first understand what we are doing wrong in medical education that's contributing to age-related biases, talk about how ageism is affecting clinical care for older adults, and then reviewing strategies to combat ageism in medical education, as well as then practicing them in small groups, just so we can talk about how to address these situations. And so if you can think of situations that have occurred during your practice, start thinking about them now, because we will come back to them at the end and try to poll the group on how to address things that y'all have experienced yourselves. So first, I have the pleasure of talking about what we are doing wrong in medical education. First of all, the traditional way we are teaching how we're approaching medical care is biased against older adults. Typically, what we're teaching people is the simple presentation or the textbook presentation. So how to approach the API, how to diagnose a PE, with the simple, hopefully younger male healthy patient who will benefit from a simple intervention such as a surgery, antibiotics, or something along those lines. What we're missing is the complexity of older adults. So oftentimes these simple situations do not include the complexity of our older patients who maybe have multiple cognitive, functional, medical comorbidities. And these are much harder to include in a multiple choice question for your medical students who really just want to learn how to diagnose that MI on an EKG or diagnose that API. Especially with the siloing of specialty-specific education, which is starting early and earlier, this is also compounding the problem. With the pass-failing of multiple classes, as well as step one, people are really dedicating and committing themselves to a surgical subspecialty or a different medical subspecialty very early on in order to get those letters and make sure they can show their dedication. And what that can kind of miss is the breadth of their education, especially with something like geriatrics, which may not be as appealing from the get-go for multiple reasons, but it may not attract a crowd early on in education. It may take time to develop that interest. And so the siloing of specialty education can really make things difficult for things like geriatrics. On top of that, a lot of our evidence is lacking. So a lot of these interventions that we'll talk about focus on the preclinical coursework, but not on the clinical education. And there really isn't great evidence to talk about how we approach ageism in medical education. And what this leads to is that medical students are developing an age-related bias. So there have been multiple studies that show implicit and explicit biases against older adults. And I think this correlates with a lot of things that we are seeing. I can probably count on one hand the amount of medical students who I've talked to who are interested in geriatrics from the get-go by the time they reach their clinical years. And I think that's probably pretty similar for a lot of us. Furthermore, our own death anxiety and thoughts about aging contribute to this ageism. I know, thinking about getting my first gray hair and already thinking of my will for my dog and what I'm going to leave her, which can contribute to our own ageism and how we approach this. Finally, this bias persists through medical training. So unless we are actively addressing it, this is going to keep going. It is a modifiable risk factor that we can talk about, but unless we actively address it, this can persist. And additional research has showed that even with just exposure, our medical student opinions regarding their elderly patients will actually decrease throughout medical school. So just exposure to older patients is not enough. We actually need to address this ageism head on to make sure that we are creating positive opinions and actually educating our medical students on the best approaches for how to deal with our older patients. And finally, another consequence is that this ageism persists through treatment recommendations. So another reason why we really need to start this early and be proactive. There have been different studies that show that medical students making decisions are going to offer less aggressive treatments. And this affects everyone, really, in all different specialties, which matches with multiple different studies, previous and since then, that based on attending decisions. So in different studies looking at hospitalized patients, even with controlling for prognosis, age, we're still withholding life-saving treatments for our older patients as compared to our younger patients. And granted, medical students and residents are not making these final decisions, and it's definitely like on us to make these final decisions. But if this is consistently working its way up the chain, this is what persists throughout. And those people who are making these decisions as medical students, unless it is addressed, are going to continue making these biased decisions as attendings. And now I pass it off.
Thank you. All right, so I promise we will offer some hope towards the end of the presentation, but now I'm going to talk a little bit more about the consequences of ageism. So some of the consequences of ageism in clinical care is that it can overall decrease the quality of the care that we give to our patients. Additionally, our patients can start internalizing the negative beliefs that some of our clinicians may have, which prevents the elderly adults from even coming into the ER and to seek care. And then finally, there's reduced patient autonomy. I'm sure you all have seen something like this, but often older individuals' preferences are not listened to or often dismissed, especially if they are in the presence of other individuals in the room. So that's something to keep in mind. Some other consequences of ageism in clinical care is that, unfortunately, despite having an aging population, there is still not much popularity in learning about geriatrics. And then additionally, in research, there's lots of underrepresentation in the research towards our older patients. A lot of clinical trials often have age caps at who is included in these clinical trials. About 1/3 of trials on type 2 diabetes and cardiovascular disease actually have a cap on the ages of people who are included in those studies. So that adversely affects the care that we can give to our patients. And then finally, there's a lot of assumptions that aggressive treatments would not be beneficial to elderly individuals despite people's functional status when they first present to the ER. So what are some interventions that we can do from an education standpoint? Studies have shown that empathy-based interventions have the greatest impact when we are learning about geriatrics. And then additionally, providing knowledge and clinical skills increases confidence in giving geriatric care, and having intergenerational contact with our students and with patients can help positively shift attitudes towards aging patients. So what are some other clinical-based strategies that we can do for bias reduction? Students with intergenerational programs, some medical schools have programs like this, show greater empathy and respect for elderly patients and for elderly individuals. Additionally, medical students without geriatric exposure often still had ageism biases. So it's really important to have that contact with patients. And then additionally, applying education with clinical practice can significantly reduce stereotypes. And then, so what are some opportunities for change? So this is where we'll kind of shift it into kind of more positive things that we can do in the future. So overall, this is a modifiable risk factor. Ageism is a modifiable barrier. We can change this with some educational interventions. I think the most important things that we can do moving forward is to kind of teach and recognize the challenges and assumptions in clinical decision making. And then finally, we can include having inclusive conversations, encouraging patient-centered discussions. And then we will also need to educate ourselves as faculty members for how we can do better for our medical students and for our patients. And now I will hand it off to Dr. Rowe.
All right, so we're going to talk about how we do this. So we went through some of this type of faculty development, and we know that students actually learn the most and reflect the most from their clinical experience. And what we found was that even after everybody had this knowledge and thought about it, what you do in the clinics is actually really difficult. And so first, I want to open that space that what you do as faculty is important and difficult. Did you give me the clicker? Because I kept my coffee instead of the clicker. So what we wanted to do now is actually practice some of those spaces that our faculty found themselves in. So what we're going to do is give you a clinical case, and we want you to act like you're the preceptor, you're the attending during this time, and what would you say to the medical student if you found yourself in this situation? And all of these are real life. So the first case, you're observing a medical student complete the history and physical for a 76-year-old female patient. She presented with dysuria, confusion, and fatigue. She's tired but alert and oriented. The medical student asked one question of the patient and then completed the rest of the discussion with the patient's son and husband, even though the patient was alert and watching the discussion happen before her. So you leave the room with the medical student, and what do you say to them? So the goal for this is to turn around, talk amongst yourselves, take a little experience, get to know the person around you, and come up with what you would say to that medical student right after you see this happen.
As an unloved person, discuss.
All right. Does anybody want to share what the group came up with?
I will share.
Sure.
We talked just about why didn't you ask the patient the questions? And I usually start with the what was the barrier for asking the question? Like I use that, what was the barrier? I use that a lot as my intro to, especially when they did something I didn't like, and maybe they're gonna start to learn and I need to change my language so that it's not like the Robin always said, what's the barrier? You know, you did something wrong, but it's what was the barrier to asking the patient the question? So that then they'll be like, she didn't understand me. And I'll be like, what led you to believe that, right? And then you just kind of figure it out. So that is.
So you have a phrase that you use when you want to call out something that wasn't done well, but don't want to say it negatively. I mean, so that's fantastic, right? So a lot of when the attending came with this, we won't we'll leave them unknown. They said I wasn't sure what to say to the medical student because I'm so afraid that if I call them out, then I will be accused of like pimping or putting them on the spot. But I really didn't feel comfortable with what they did. So that's a great way. Until they figure it out, that's awesome.
And sometimes they'll say, I'm curious, why did you? That's the other. I agree. What was the barrier? Which is usually like you did something kind of stupid. Or I am curious curious. Why did you speak to the family only? But, those are my two go-tos.
Awesome.
We had a slightly different way of approaching the same thing. Judy phrased it like, did you notice that this is what happened? I saw you interacting mostly with the family, whatever. Did you notice that that's what you were doing?
Right.
As another way of sort of opening the discussion.
Nice.
And also Alan suggested where the keep your parent outside, then maybe you send the patient back, or you send the student back in the room, and you're like, hey, let's try again, like chat with the patient and get the history from her. The history you get from the patient will be the best perspective.
Mm-hmm. Wonderful. Other ideas? All right. I thought this was kind of a soft one too, so we wanted to start with it. So this is case 2. You are alerted for an incoming trauma. The patient arrives in a cycling outfit and a helmet, but it's difficult to see the face as he's being transferred to the gurney. On initial review, the patient sitting before you, he has a deformed left lower extremity, turns out to be a tibial fracture, and he's holding his left arm close to his chest, conserving for a clavicle fracture. Upon removing his helmet and clothes, he's noted to have only scant white hair and wrinkled skin, clearly an older adult. The medical student huffs and says, OMG, what is he even doing on a bike? What feedback would you provide? Discuss this one.
Manage your face.
So this one brings out the explicit thing. Yeah, same thing you want to like. Now, sure, guys, I'm actually that's it's like I feel like I'm not even in this like by giving you the chance to like is there a service or is there like so you're out of line, get your stance now. Like, and I know that's not like so that respond to that. And I think I mean it's I mean, that's not for you, that's like, actually, I didn't even want to. You know, like, yeah, like, for your feedback, but, you know,
didn't answer those questions. Yeah, it was like a conference. Their work is going to work and
Okay, it sounds like some of the talking has stopped. I saw a little bit of violence in response. What would you say to this medical student? Mm-hmm.
I'm curious what the problem is. Is it that the student said this in front of the patient? Or is it that they even thought that an old person belongs on a bicycle? Because those are two entirely different problems.
Right. So this is different than the other case. So as the attending here, you have to deal with multiple issues, right? What are the issues here? You brought it out. Like there's clearly disrespect that's happening in front of a patient who I didn't tell you whether they were awake, but they were awake. So there's that issue. There's a professionalism issue. And then there's the belief that led this person to say that, right? So there's two different issues, right? So you have to decide which one you're going to go at first. So let's say you're not the clerkship director like Dr. Davis is here. So you're going to go at the beliefs that got them there. What would you say?
I'll go again. So I am a person who uses humor to deflect microaggressions, and so right, like there's multiple different ways you can approach this, but I usually use humor. So like, yeah, and I think this is one of those things that I would say something to the student, like with the patient where they can hear me, so that the student, because otherwise the student, like the patient might hate the student or something.
Right.
So I would probably say something like, he's much fitter than I am, he has more business on being on a bike than me, or like, he could outrace me any day, or something like that, just to be like, hey, like that was, just to kind of call it out and say, this person, kind of like put it out into the world of, they have every right to be on a bike, they're fitter than I am.
Yeah.
And then later on, outside in front of the patient, that was a completely inappropriate thing to say.
So you have like patient upstander training. Like you're like, I'm going to not let this microaggression go because I think this was damaging to the patient. I'm going to address that first, usually in a self-deprecating or humorous way. Perfect. Definitely one way. Other thoughts for the initial response? So I'm a very evidence-based person, which not to say that anybody else isn't, but I had so many things that wanted to like jump out of my mouth about risk of traumatic injury for older adults and importance of physical activity as we age. So many guidelines. That's where I started. And there were so many things that this was clearly my case and my medical student, that I wanted to say so many of the things at once that at first, like, I couldn't say anything. I was just shocked. I mean, I was the attending dealing with the patient in a situation where this person was a trauma activation, but was not the level that required trauma to be at the bedside right away. So this was my patient. But unpacking the beliefs that student had to make them make this comment, what do you think?
I think you need to ask first. I think it's very easy to walk into this with an assumption of what's going through the mind of a medical student. But unless you ask the question and try and get them to explain
Sure.
what led them to say that. It could be that they looked at the individual and they were emaciated and frail, and that's why they shouldn't have belonged on a bike. I don't know. It may have been simply old people don't belong on bicycles. But unless you ask the question, I don't think you can start.
Great. I think that's a great place to start with. So I did ask that question. The student said, don't they know that there's a risk as you get older, you're more likely to die from trauma? They felt very proud of their recent learning that had suggested older people are at higher risk. So where do you go from there?
So I'll take that bait every time. The residents that have worked with me know that if we start playing the evidence game, I'll take that bait every time. And I would counter that with, that's a great point. Can you be more specific? What do you know about trauma and age as a risk factor? Like, there's a lot there. So A, first tell me what you know. B, tell me what you know about the benefits of riding your bike as you get older. And then now that we have this giant landscape of evidence on the table in front of us, how do you counsel an individual patient about the risk and the benefits? Because that's a whole entire conversation that's totally valid. And obviously we're in ongoing research, but I think that's a great place to start.
Absolutely. So I took that bait as well. And we did have a long discussion, which was relatively fruitful, about the risks and benefits. And I do think there was some understanding that was gained about what it means to have risk and what it means to have benefit in the same activity and what that means as you age. However, I don't feel like that conversation actually addressed the underlying ageist beliefs that made this student say this thing in that situation. And so, yes, I think equipping people with data and information is always my go-to, but in some ways that conversation felt a little empty because there was clearly an underlying bias that happened there. Does anybody want to add anything to what they say to the med student?
I think it zoom out a little bit, like if I was in this case, like I think we just have a culture of like victim blaming a little bit in trauma, like people come out of accidents, are asking all these questions, and I feel like, someone makes some comment about something about, 2 years ago or something. And I think if we're sitting down with them, that was just like they not like normalize, like sometimes our first reaction is to like maybe comment like this or to say something like this or to like almost victim blame. But I would just be really careful because sometimes, you might not realize that this may show up in other ways you're practicing. So many patients are going to be over. So don't just like normalize it, but people do make these comments, but think about what it means for you as a patient.
So you want to make them feel comfortable before you tell them what barrier led you to make this comment. So I definitely think that's reasonable. I think as women we do it more than we should, but that's my own soapbox. But making somebody feel comfortable in the conversation is going to be what space they learn in, right? So anything that you can do as you're having these discussions as the attending teaching, making somebody feel more comfortable will make them more receptive to what you tell them. But I haven't heard anybody say ageism or age bias to the medical student who made that comment. Do people feel comfortable saying that to med students? Do people feel that would be productive? Or residents? This was a med student, but it's same situation.
To a resident, I would feel comfortable. To a medical student, not. Because I have a I have a longitudinal relationship with the residents. I have been for 3 years. They know me and we have a relationship such that if I clearly and explicitly say that they have an implicit bias, that is an ongoing conversation that we can have. A medical student I maybe work with twice in 3 to 4 weeks. And I guarantee you that's coming up on my evaluation.
Yes, it is. But who has that longitudinal experience with them and the experience at bedside where they can provide that feedback?
I'm saying it's right or wrong. I understand how I would dance around that like a tango.
I like the honesty. I would expect nothing less from you.
I think it's okay to say it to the medical student. Tell them, let them understand what your experience is. And let them understand in this case, they were somehow in their mind, they perceived inability to do something based on a presumption of an age. And really, you can have, I don't know how old this gentleman was, but my guess is they're older than 50, older than 65, and highly functional because he's got a cycling outfit on, he's got a helmet. This is not his first time on a bike, and not his last probably if he heals. So I think, to assume that someone's older is also, it's a number, but it's also more importantly based on function. And I think teaching them, and we have to start with medical students because they're going to become residents someday, and then they're going to carry on, I think, maybe these biases. So I think that I think we should all feel empowered to say something to that. Cause I don't have one, I get medical students like kind of a cross section at a time, and I usually say to them, I can't teach you much, but I'll teach you stuff about geriatrics.
Mhm.
And that's what you're gonna get out of your shit.
Yeah, I didn't put the patient's age on there because the medical student didn't know the patient's age either at the time, which I thought actually was a very interesting part of the, like, obviously I've thought about this case quite a bit and ended up doing cycling research in age, but which my resident is presenting on Friday if anybody wants to see it. But there's so many components to this. The medical student did not know how old the patient was. And so in some ways it was hard for me to say this is ageist because I didn't even know how old the patient was. So it, you know, if he was 87 or if he was 52, what does that mean? Like, you're making assumptions about this person's risk based on how they look. And as someone who has no interest in Botox, like, I'm a little afraid that I'll be looked at as ancient in a few years, right? But what is she doing X? Well, hold on. I'm not that old yet. And then the question is, what is leading to thinking that anybody can't do anything? And I think the discussion of function is super important. And I think moving it back towards a discussion of function and not a discussion of age is certainly more productive in these discussions, but it's not even how we do it in the literature. It's not even how we do it when we do research on these topics. And so I bring this up as an example because as we started to talk about improving the way that we expose our residents and our medical students to clinical scenarios that involve ageism, we also had to equip ourselves and practice how to talk about it. Because sometimes when these things came up, even those of us who are very much involved in this and very passionate about improving care at all ages, felt like we didn't know exactly what to say. Not that there's a right answer that's going to show up here on the slide, but that all of these are techniques that everyone's talking about. Because I did see a little bit of violence in the audience when I first put this up there, and I think sometimes that's your first reaction, and it actually keeps us from being able to have a dispassionate conversation with the medical students at the time. Because much like my children, the medical students don't like it when I get worked up about something, and so approaching it, knowing how you're going to approach it before you see it is very helpful. Any other last thoughts about this case? This guy did great, by the way, and he does cycle now. Okay, this is the last one. A 90-year-old female presents to the emergency department in respiratory distress from a COPD exacerbation. She is initially stabilized on BiPAP, but with worsening labs and mental status. The team must decide on intubation. When talking to her son, who is her power of attorney, the junior resident leads the discussion. They start with, "Your mother is such a little cutie and I'm so sorry that she's sick." Then they discuss next possible steps as intubation or continuing BiPAP. The resident concludes with the statement, "She looks like she has lived a good long life, so why don't you come sit with her while we make her comfortable?" A breathing tube may just hurt her more than help her at her age. How would you provide feedback to this resident?
It's not your place to judge the quality of others. Also, like technology, right? This way, right, exactly.
But I applaud the attempt to accurately form that work.
Okay, it sounds like there's a lot of great discussion. I- Does anybody want to share what feedback they would provide for this one? Okay.
Your like the infantilization of like your mother's sexual beauty,
The infantilization. Mm-hmm.
especially to a family member. I feel like we hear a lot like behind a computer.
Yes.
I'm presenting a patient and let it slide there, but I don't and like talking to a student who's presenting, I don't even know where I'd start there as opposed to the like goals of care jumping to the goals of care recommendation without all the other steps before getting there, like listening to the patient's wants or needs. There's a lot of conversation that should have been had before providing a recommendation and making it more complicated.
Mm-hmm. Mm-hmm.
A lot of questions that are left unanswered.
I think my feedback to the resident would be offline and subsequent, but I think I'm actually most concerned with rescuing the conversation.
Mhm.
Because there's a goals of care conversation that needs to be had, that needs to be reopened.
And I do know, I will say that there was a further discussion that was taken over by the attending that sort of discussed functional status and goals of care and sort of a more complete understanding of the total picture. So I don't want you to worry about this patient either. So certainly you can have a conversation with a junior resident about whether they got to the medical care that they should have gotten to and whether they gathered the right information in order to get to that medical care. Absolutely.
I think it was just kind of brainstorming some alternatives. Like I said something really like this patient, like I can see we're trying to like warm up to them and it's older family, but we just have to be careful. You know, sometimes older patients can get infantilized, and I try to be really careful with the language I use around them. There's other words, maybe like lovely, your house is so wonderful, you guys have a great family. Like let's try maybe some other phrases.
Okay. So that's a great thought. And a lot of people talked about that when we talked about this case as faculty. And one of the parts that I struggle with is changing someone's words the same as changing their perspective. And I'm always concerned that if I give individuals tools for saying something differently, that I haven't necessarily changed what got them there. But yes, they need to change their words. Other thoughts for this? So I'll tell you what we talked about as a way of sort of getting through this with the resident. So oftentimes when I find that trainees are using words that are inappropriate for the situation, what I ask them to think about is whether they would describe a different patient this way, right? So you think about it the same way you think about gendered recommendations, right? Would you recommend that to a male patient if you recommend it to a female patient? Would you recommend that would you say that about a 30-year-old? Would you say that about this other patient? And if the answer is no, then I want you to take a little bit of time to think why you would use it in this situation and if it's okay in this situation. And then I step back. Because honestly, I think the real answer is I'm not going to change anybody's perspective by anything I say to them. The only thing I can do is ask them to think about it and come up with something different. So particularly when it relates to language. Would you use that phrase? Would you talk to that patient that way if they were this patient? Would you say that to the patient if they weren't incarcerated?
I think in these type of situations, I think one of my weaknesses is I do a little bit more talking than what you just described, which I think you made a really valuable point. I think if I'm being honest, the way I would probably approach this, everybody else has already said a lot of important things. I tend to try to remind learners of their context in this whole role, their position in this whole drama, right? And one of the aspects of that is the power differential between us as the healthcare industry, whatever, and them as the lay people, right? That if you call somebody a cutie, downhill on that power differential, that's, you know, like you said, if you transplant that dynamic into a different relationship, that's sexual harassment, that's whatever, like you can clearly see that that's wrong. And sometimes reminding student physicians, trainees, whatever, about that power differential that they inhabit is something that they forget or they take for granted, or they stop noticing it. And so sometimes reminding them that that power differential exists, I do get a little light bulb from them sometimes. The other thing that I try to remind people is about all the assumptions that they're making, right? When they say something like, she looks like she's lived a good and long life, or even something as seemingly benign as your mother seems lovely or whatever, maybe she was a horrible person.
That's the first thing that went through my head.
You never know, right? And it doesn't matter. Everybody deserves good quality medical care or whatever, and that's the point. is that by calling somebody lovely or good and long or whatever, you're assuming a whole bunch of stuff about things that have really nothing to do with the decision that's in front of you. So for me, the scripting that I use for this kind of conversation is very neutral and very universal. It's things like, in the ER, we deal with these situations all the time where people are very sick and family members have to make decisions about their health care. Like, trying to make it as normalized as possible. And then give them a chance to, like, land anywhere on the spectrum that they want. Like, different families make all kinds of different decisions about their health care, and there's a lot of different reasonable ways to approach a situation like this. And then I feel like people's guard goes down a little bit, and you can then sort of do all the other things, like take the conversation the way it's supposed to go if you have to rescue it in the moment or whatever, or if I'm just coaching a student later. I feel like those scripting chunks or whatever are easy enough to remember that they can put in the file.
Other thoughts on this case? Yeah, I think a lot of good points have been made. I think bringing these discussions with learners back to function and goals of care are always important. I think being prepared to call people out when different things are said, and everybody has different ways of doing that, same spiel. Many different teachers will use a variety of different ways in order to tell the students they did a bad job, and whatever way is most comfortable for you is the right one, right? That's definitely true. These things come up on reviews all the time, and we have to be realistic as educational institutions that if we say things that are hard to hear, then we will likely get it back. And so doing pre-work on how you're going to manage that as a department is super important. And I think one of the things that people feel supported on, our faculty feel supported on, and one reason that they feel comfortable calling some of these things out. Definitely addressing sort of the medical care and then the underlying issues as sort of a stepwise process we talk about. But I hope the other thing that these have illustrated is that even when you care a lot about a patient population or doing something right or addressing an ism, it's very hard to do in the moment, and these are the situations where students learn the most, right? And so, is that a hand? Having these practices, the goal of addressing this is not enough without the practice, usually beforehand, of addressing these and having the way that you plan to talk to students about it.
I was going to ask if you have any advice for how to address our faculty peers about this. So for instance, at our shop, we see a lot of people on our own, like it's not resonant. And I was watching a sign out for one of our faculty was saying, this is a 90-year-old whose chief complaint was, I just don't feel right. And the other one was like, oh, come on.
Yeah.
Like just fling around like that. And I was just like sitting there listening to this with some learners at the doctor's. I was like absolutely horrified, but I just couldn't find it in myself to say anything at the moment. Because that's just what I am. I just need to process.
Yeah.
And it's hard for me to be confrontational with, my peers about something I care about because they probably know. So I just want to see.
Yeah, so the way that we talk about giving that kind of feedback to peers or even up is like our up standard training, which goes through like the D's of response. And I could definitely give you a great lecture that's on YouTube that Emery put together that gives sort of the ways that you can address this. And there are basically 6 different ways that they talk about, and usually one is most comfortable. It's never easy, and it always feels like you're putting yourself at risk when you go out on a limb for what benefit. I think one thing is when we're tasked with training trainees, you feel like there's a reason for this. If you're addressing something with a colleague, you're like, oh, they're going to ignore me, and they don't care what I think. But there are some sort of more subtle ways that you can bring these to light. Holding people accountable is then more difficult. other thoughts or questions? Well, I hope this was helpful. We finished 1 minute early. Woohoo! Happy to stay at the end for any discussions. Happy to share these cases. Definitely think it's worth a discussion with faculty that are going to be working with trainees. Thank you so much for coming, and I hope this was useful.